Hello, everyone. My name is Gurja Basra, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on chronic lymphocytic leukemia and small lymphocytic lymphoma. And just before we start, I do want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. If you have a question, this session will be followed up by a live Q&A session, so keep your questions in mind and be sure to attend the Indolent Non-Hodgkin Lymphomas and CLL/SLL Q&A afterwards. So to introduce our speaker today, we have joining us Dr. Graham Fraser, who is an associate professor in the Department of Oncology at McMaster and a hematologist at Juravinski Cancer Center, Hamilton Health Sciences, with a large CLL and lymphoma practice. He is the program director of the Adult Hematology Residency Program and chair of the Department of Oncology Fellowship Program. His research interests include clinical trials in CLL and lymphoma, and he practices guideline development as a member of the Cancer Care Ontario program in evidence-based care. So thank you, Dr. Fraser, for joining us today, and you can get started as soon as you're ready.
Thank you so much, Gurjat. It's a pleasure to be able to present this breakout session to you all. These are the objectives for the next 45 minutes or so. I'd like to review some of the background epidemiology, the diagnostic criteria, and clinical presentation of CLL and SLL. We'll review the indications for treatment and spend some time discussing the principles of active surveillance for patients who may not have an indication for beginning CLL-directed therapy. We'll then focus on an approach to first-line treatment that'll really talk a little bit more about the issues and aspects of both patients and their disease that helps us decide on one treatment over another, rather than focusing on a lot of data and slides relating to clinical trials. So we'll try and keep that a little bit more broad and general. And then we'll discuss an approach similarly for managing relapsed disease and finish with some brief discussion about future directions in clinical trials. To begin with a brief overview, CLL and SLL are considered the same disease, with really the only difference being the burden of disease circulating in the peripheral blood. It's a slow-growing or indolent, incurable cancer of mature B lymphocytes or B cells. About 90% of patients have the CLL phenotype, where there's a sufficient burden of circulating tumor cells in the blood to meet criteria for that, and about 10% have SLL. The disease is marked by a lot of clinical heterogeneity, meaning there's a really broad range of how patients can present and how their CLL progresses over time, from those that may be extremely indolent and never require therapy over their entire lifespan with the disease, and those who may have disease that behaves in a more proliferative or aggressive way. But we've certainly developed a much better understanding of the underlying disease biology, and there are a number of clinically relevant prognostic markers that have resulted in allowing us to understand this heterogeneity and apply that to improve patient outcomes. And importantly, treatment is only indicated for patients who have symptomatic disease progression. And so those who are asymptomatic will be managed with active surveillance, and we'll talk a lot about that over this talk. And the outcomes have really improved quite dramatically over the last 10 or 15 years, primarily as we have moved from a chemotherapy approach to a more targeted drug development approach. But along with that, with increasing number of options, the treatment decision-making has also become somewhat more complex and needs to be individualized based on a variety of factors. CLL is a disease of older patients, primarily, with a median diagnosis of 72 years. About 2/3, therefore, over the age of 65, and a relatively small proportion are younger than 50. Rarely, you may see patients in their late teens and 20s, although that's quite unusual. There's about 1,700 patients diagnosed each year in Canada. The prevalence is much higher than that, probably tenfold higher than that. And that relates really to the long average life expectancy associated with managing CLL in this more modern era. There's a slight male predominance, as well as a predominance in Caucasian populations. A lot of questions are asked at the time of diagnosis about what may have caused an individual's CLL. So sporadic cases, really, I would say causes have not really been well established. There are a number of associations in the US that were exposed to Agent Orange have benefits to cover therapies related to CLL. Organic solvents, pesticides, farming, and other causal links have been proposed, but the mechanisms for the establishment of CLL in patients is really not clear, and there really are not any clear preventative or screening strategies that are effective in being able to help sort that out. Familial CLL is also recognized in about 5 to 10% of patients with a first-degree relative. And if you look at patients diagnosed with CLL and you interrogate their blood of their first-degree relatives, if you really dig deeper, you can find a small clone of CLL cells in perhaps up to 20% of patients. So that the underlying underpinnings of the familial CLL is also sort of still being worked out, but it is certainly something that is well established, and being aware of one's family history is important and may have an impact on their family members with respect to care through their primary care providers. This slide focuses on the diagnosis of CLL and SLL and tries to distinguish it from the precursor or pre-leukemic diagnosis of monoclonal B lymphocytosis. To establish a diagnosis of CLL, you really need primarily one thing, which is a peripheral blood CLL count or monoclonal B cell lymphocytosis greater than 5 times 10 to the 9th per liter. If your peripheral blood mononuclear or monoclonal B cell count is less than 5, if you have affected nodal disease or hepatosplenomegaly, we would consider that SLL. So again, CLL and SLL, small lymphocytic lymphoma, are the same disease that present in slightly different ways, with the predominance of disease in the lymph nodes and liver and spleen with SLL, and at least a burden of disease in the peripheral blood required to make a diagnosis of CLL. And if you just have a small population of cells in the peripheral blood without any involvement in the nodes or spleen, we call that monoclonal B lymphocytosis, which is really, again, a pre-leukemic or pre-cancerous state that has the potential to evolve into CLL or SLL at a rate of about 1% per year. The slide here shows the typical morphology of small mature lymphocytes, and there's a characteristic immunophenotype. So blood samples can be sent to get a specialized test called flow cytometry that can characterize the proteins on cells and enable a diagnosis of CLL and distinguish CLL from related indolent B cell lymphomas, which may also present with tumor cells circulating in the bloodstream. It's very common for the initial presentation to be an elevated lymphocyte count on routine blood counts done for other reasons through a primary care provider. Lymph nodes may be enlarged. These may be asymptomatic, but can become tender or more uncomfortable. You can have enlargement of the liver and spleen. This may cause abdominal discomfort or bloating, or what we call early satiety, meaning that you may feel full quickly when eating a meal because of compression of the stomach by an enlarging spleen in the abdomen. These symptoms are disease-related fevers, drenching sweats, or weight loss. Probably more commonly as associated CLL and SLL are associated with weight loss, but you may see the other B symptoms listed there. And symptoms developing related to low red blood cells, platelets, or low white blood cell count or neutrophil count related to marrow infiltration by the abnormal leukemic cells can lead to additional symptoms related to what those cells do. So in the case of red blood cells that are carrying oxygen to the tissues, anemia would present with fatigue or weakness, perhaps shortness of breath. bleeding or bruising symptoms. If platelets are low, they're the cells in the blood that initiate the initial phases of blood clotting, and low neutrophil counts can be associated with serious infections. It's often asymptomatic at diagnosis, especially if it's picked up as an incidental finding on blood work done for other reasons. Initially, symptoms may include, as I've mentioned, lymph nodal enlargement and progress through low blood counts due to marrow infiltration. There can be other manifestations that we'll speak about in a bit more detail. Low immunoglobulin levels or antibody levels can lead to an increased susceptibility to certain types of infections. And there are some unique complications associated with CLL and SLL, including autoimmune attack of the normal red blood cells, platelets, or white blood cells. Richter's transformation is a syndrome whereby an aggressive lymphoma may evolve out of the background of CLL. Patients may describe an exaggerated response to insect bites. That's a very common observation that patients have in the clinic. They are often suboptimally responsive to vaccination, although that does not mean that vaccination is not helpful. In fact, it's strongly encouraged, as we'll talk about shortly. And there's an increased susceptibility to other malignancies, in particular skin malignancies. Staging of CLL is slightly different than other lymphomas that you may hear about over the course of this conference. The RYE staging system has been used in North America, initially published in almost 50 years ago now, which is a system that results in varying stages from 0 to 4 based upon the presence or absence of lymphadenopathy, splenomegaly, and low blood counts. So stage 1 disease, stage 0 disease would have a lymphocytosis only without any other manifestations. Stage 1, you would have lymph nodal enlargement. Stage 2 would have liver or spleen enlargement, and stage 3, anemia. Stage 4, thrombocytopenia or low platelets. So this is really a system that reflects the increasing burden of disease. Of course, it's circulating in the blood often with CLL at least, and so the staging system is different from that of other types of malignancies. There are a number of prognostic markers that, again, have been helpful in understanding the behavior of the disease in patients and are also often very important to understand when it's time to make treatment decisions. High-risk CLL is characterized by mutations or deletions in the so-called P53 gene, an important tumor suppressor gene, and the immunoglobulin heavy chain gene. Mutational status is also an important prognostic marker in CLL. So low risk disease would be characterized by an absence of a P53 mutation or deletion, and IgHV mutated status. High risk disease by the unmutated IgHV or abnormalities involving P53. The initial workup of someone in the clinic would include a complete history and physical exam, looking for manifestations of the disease and complications related to it, some limited blood work and flow cytometry to confirm the diagnosis. Prognostic marker testing is generally only recommended when treatment is indicated because the results of these tests do not influence the timing of treatment. They don't tell us when treatment is required. That's dictated more by the development of symptomatic progression of the disease. But when treatment is required, they can provide important information that might help choose the optimal therapy for you. Generally speaking, in contrast to other types of lymphomas, CT scanning at baseline or PET scanning are not routinely organized. They can be important if there are symptoms present, and sometimes we'll use PET scans if there's perhaps a concern about more aggressive disease or Richter's transformation. But in general terms, radiographic investigations, particularly early on in the disease course, are not perhaps as important as they might be in other lymphoma subtypes. And generally speaking, a bone marrow aspirate biopsy is really not necessary unless there's a need to investigate the cause for low blood counts. Treatment is indicated if there is symptomatic progressive disease. And this is a list of common indications to initiate therapy. For patients who developed progressive marrow failure related to infiltration of the bone marrow by the CLL cells, almost crowding out the marrow so that the healthy blood cells can't grow, significant anemia, low platelets, or low neutrophils would be a potential indication to begin treatment. Marked or symptomatic splenomegaly, lymphadenopathy, B symptoms. And for patients who have a fairly rapidly progressive lymphocyte count, we'll talk about a doubling time of less than 6 months, which really is something that has to be taken with some context. This is really trying to get at a situation where the disease is clearly got a more rapidly proliferative growth pattern. It's not really a question of, if treatment will be needed, but when treatment will be needed. If it's clearly advancing rapidly, there may be a decision made to get on with therapy before complications develop. Autoimmune cytopenia is poorly responsive to steroids and any other sort of dangerous manifestation of the disease. Sometimes it may involve unusual sites or sites that are perhaps threatening other organs, liver and kidneys, for example, and treatment may be required in those situations. What's not on the list are the degree of lymphocytosis. So there's not a magic white cell number where treatment must be initiated. The lymphocyte count can sometimes get into the several hundreds, and if somebody is asymptomatic and feeling otherwise quite well, there wouldn't necessarily be a need to initiate therapy. I would say that it's quite common for patients, once the white count gets over 3 and certainly 400, that most people will have an indication to therapy, that an indication for treatment that will be present. It's also, what also is not on the list is prognostic biomarkers. So there's still not a specific mutation that would benefit from early initiation of treatment. And recurrent infections is also not on the list to begin therapy. Recurrent infections actually are going to be only exacerbated by initiating therapy, which is generally, to varying degrees, immunosuppressive. So early stage asymptomatic disease and this question of whether immediate therapy versus deferred treatment is best has been evaluated for decades. This is an old slide dating back to the 90s, capturing data from multiple studies that looked primarily at older chemotherapy regimens. And these trials are conducted in a similar way, taking patients in the asymptomatic early phase and randomly dividing them into patients who get treatment right away versus patients who would simply be monitored, and at such time as they develop symptomatic progression, initiate therapy at that point. And what these trials have all demonstrated is that patients who start their therapy early do not have improved long-term survival compared to those who simply wait until the disease progresses. As a general principle of treating patients with almost any malignancy, your goals of treatment should be to improve the length of life, overall survival, or the quality of life. And it's perhaps maybe obvious that you can't improve quality of life by giving somebody chemotherapy or some form of treatment if they're otherwise asymptomatic. So these early stage studies looking at early introduction of chemotherapy have not been able to show an improvement in overall survival or quality of life. And that really has established the paradigm of active surveillance for patients who are in the asymptomatic phase of their disease. And it's a question that continues to be asked because over the years, we've understood and maybe feel a bit more able to pick out patients who might be at higher risk for poor disease outcomes. But also there are novel agents and new approaches that are more effective in managing the disease. So this question has been asked more recently, even in the era of effective chemoimmunotherapy and targeted therapies. And so far, there has still not been a strategy that has clearly demonstrated improvement in survival with early therapy, regardless of the risk subgroups. There's currently a randomized trial that the Canadian Cancer Trials Group is participating in, led by Dr. Versha Banerjee, evaluating this question, again, using a venetoclax and obinutuzumab-based strategy. So we await with interest the results of that study, but so far early stage asymptomatic disease is managed with active surveillance. So the principles of active surveillance are outlined here in simplified terms. You're monitoring for symptomatic progression of the disease or disease-related complications. The frequency of monitoring can be quite variable. It may be as infrequently as annually if the disease is behaving in a very indolent way, or if there are concerns of disease progressing, maybe every 3 or 4 months. You're looking to determine if there's an indication for CLL-directed therapy and making sure that there are not any disease-related complications going on during these assessments. You're also looking to try and manage and prevent complications related to immune compromise, which really falls into the 2 categories of infections and second cancers. And of course, trying to optimize general health and holistic well-being is actually a very, very important part of this. It's a difficult diagnosis. There's uncertainty related to the disease and disease outcomes. And it does take some time to become familiar and as comfortable as possible managing things in the asymptomatic phase. It's sort of counterintuitive to everything many people think about malignant diseases, which is to try and get treatment initiated as early as possible to improve outcomes. And when we're letting patients know that we're not going to actually treat the disease, but follow it and wait and see, that can sometimes be a challenge. Autoimmune complications in CLL and SLL occur in about 10 to 15% of patients. Usually this is related to the blood counts. So the immune system inappropriately is recognizing the red blood cells or platelets, rarely the neutrophils, sort of attacking and breaking them down more quickly than they should be. And that can lead to a drop in those counts. Autoimmune hemolytic anemia resulting in a low red blood cell count is probably the most common, occurring in about 10% of people. It may also affect the platelets, leading to low platelet counts and bleeding problems. Evans syndrome is a particular syndrome where both ITP, the attack on platelets and red cells, occur concurrently. And then there's some very, very rare situations where the bone marrow may not be able to make red blood cells at all, or the neutrophil count can be lowered and increase susceptibility to infection. These are maybe a little bit more challenging to diagnose, particularly the last one. There may be other autoimmune diseases, very uncommonly, but things that we occasionally see in the clinic related to other autoimmune diseases affecting the skin or kidneys. But in general terms, what we see most commonly for sure is the autoimmune cytopenias. We've talked a little bit about Richter's transformation. So just again, this is the development of a more aggressive lymphoma in patients with pre-existing CLL and SLL. Normally, this is a large B-cell lymphoma. Occasionally, it may be a Hodgkin lymphoma. It often presents with a more rapidly enlarging mass and more rapidly progressing symptoms is often the clue in the clinic that might lead us then to investigate and biopsy suspicious masses that to try and confirm histologically if that is present. Probably 5 to 10% of patients over the course of their disease will be diagnosed with a Richter's transformation. And generally speaking, they're treated with combination chemotherapies that would be similar to their de novo counterparts, large cell lymphoma and Hodgkin lymphoma. It's a challenging situation for sure, but one that's very important to recognize because the therapy of it is markedly different than therapy for the underlying CLL. Immune compromise is a really, really important topic for CLL patients. Infections historically have accounted for a large proportion of CLL-related mortality and morbidity. The immune dysfunction in CLL is quite complex. It's often quite variable from person to person and hard to measure in the clinic if trying to estimate individual risks of specific infections and severity of infections is really challenging. It can be intrinsic both to the disease, but also worsened by specific therapies. And I've listed some of the contributors to the immunocompromise there, including low immunoglobulin or antibody levels, marrow infiltration leading to low neutrophil counts, disease-related T-cell dysfunction, which can also be exacerbated by certain therapies. We don't do splenectomy. The last time I would have done a splenectomy in somebody with CLL, but it's something historically that maybe was done a bit more commonly, or in the setting of autoimmune cytopenias, and can be a risk for developing certain types of bacterial infections. Prevention is really important. There's strong recommendations to keep up on all vaccinations for which you might be eligible. At a minimum, the flu shot, COVID-19 boosters, pneumococcus vaccination, RSV and shingles vaccinations can be considered. Shingrix is a non-live version of the old varicella zoster vaccine, which is something CLL patients are eligible for. Although the effectiveness may be somewhat more variable or lower, our feeling is that every bit of protection is potentially helpful. And because it's difficult to predict or measure outcome, what degree of immune sort of protection one has developed, it's strongly recommended for everybody. Live vaccinations are contraindicated. This is kind of a bit of a source for concern, I would say, for CLL patients, given some of the outbreaks we're seeing with measles, and MMR is a live virus vaccine that, generally speaking, is felt to be contraindicated in patients with CLL. Immunoglobulin replacement is another strategy that is commonly employed in my clinic, at least. Low IgG levels and recurrent or severe infections would be the population of patients that may benefit from replacement with a blood product, either subcutaneously through a self-administered home program, or less commonly in the hospital through IVIG replacement. And occasionally, antimicrobial prophylaxis might be prescribed to prevent infections, particularly with certain types of CLL therapies. Second cancers have been consistently shown in a number of data sets over the last many years to be increased in patients with CLL. In particular, highlighted as melanoma and non-melanoma skin cancers, but also other malignancies. It's believed to be potentially related to the immunocompromise or immune dysfunction associated with the disease. There can also be an impact of therapies, both chemotherapy and if radiation therapy were ever to be utilized, that also may increase the risk for second cancers. So in general, there's a strong recommendation to try and avoid and reduce exposure to known carcinogens and adhere to evidence-based age-appropriate cancer screening guidelines. And this really is important to have a good connection with your family physician and make sure that these other preventative health measures are being addressed. So again, to summarize from a patient perspective, this is a difficult disease to be diagnosed with because there's a lot of uncertainty and disease heterogeneity. It's very difficult to so-called apply the average outcomes to individuals who can have quite variable outcomes. And dealing with that both from an emotional and mental health perspective as well as clinically is certainly a challenge. It's an opportunity though as well to really focus on optimizing your health, particularly in these asymptomatic early phases of the disease where treatment might not be needed for many years. Optimizing nutrition, weight, exercise, stress levels, optimizing sleep and mental health is really, really important. As I said, avoiding or reducing exposure to known carcinogens, good sun habits, avoiding tobacco products, trying to limit alcohol intake, using appropriate patient support resources, psychosocial and peer supports at your local center or through organizations like Lymphoma Canada, who are heavily invested in supporting patients and caregivers through their journey. It's really important to develop a good relationship with your primary care provider to help manage other health problems and to make sure that cancer screening and prevention and vaccinations are up to date. And just a little, I think it's a common question and a common issue that patients often explore is complementary or alternative products. And although there are no evidence-based or proven therapies that can clearly impact the underlying disease course, it's still important to make sure that you're transparent and open with your physicians and make sure that they're aware of other approaches you may wish to pursue. So we're going to move on to treatment for the last half of the talk. Treatment options have really expanded, and there are a number of excellent options for treating CLL that have been associated with very high remission rates and prolonged remissions that have translated to improvement in survival for patients diagnosed with CLL. And I think probably most of us who see a lot of CLL in the clinic would say, that we're thinking about managing this disease not over months or years, but probably now over decades, trying to find that balance between adequate disease control and managing the potential side effects and toxicities of therapy. Listed here are some of the current common treatment options that are considered: chemoimmunotherapy, targeted therapies, drugs, again, that are designed specifically to inhibit specific pathways or proteins that the CLL cell is dependent on for its growth and survival. The most common in clinical practice currently would be the BTK inhibitors, Bruton tyrosine kinase inhibitors, that are critically important for signaling through something called the B-cell receptor signaling pathway, a pathway that the CLL or SLL cells are dependent upon for their proliferation and growth, and BCL2 inhibitors targeting a protein which is important for cell survival. So these inhibitors are able to induce rapid cell death by preventing their prolonged survival. Cell therapies are also evolving. Stem cell transplants are relatively uncommonly, but in some cases importantly, utilized to treat patients with CLL. Other cell therapies are under investigation in clinical trials. Radiation and surgical options are relatively rarely used in CLL or SLL, but sometimes there may be local symptoms related to a particularly symptomatic or uncomfortable lymph node tumor that can benefit from lower doses of radiotherapy. Chemoimmunotherapy is are treatments that combine conventional, what we would call cytotoxic medications with a monoclonal antibody targeting a protein on CLL cells called CD20. And so this is a chemotherapy partner with an antibody immunotherapy, which has really, again, revolutionized the care of CLL, back about 15 years ago with regimens like FCR, which is probably the regimen that is still potentially being utilized in some patients. Bendamustine and rituximab and chlorambucil and obinutuzumab are other regimens that are slightly gentler and have been used in the past to treat older patients with CLL, but have largely been phased out because of the effectiveness of targeted therapies that we'll talk about in a second. I would say in general, chemoimmunotherapy is now much less commonly used because targeted therapies work better and are associated with fewer side effects overall. Doesn't mean to say that targeted therapies don't have important side effects, because they do, and at times those can also be serious or life-threatening. FCR, as I said, is the regimen that's been used most frequently or has kind of survived the chemoimmunotherapy era the longest, in large part because it has been effective in treating low-risk CLL. And this slide is trying to summarize that patients who have that low-risk prognostic marker status without a deletion or mutation of the p53 gene, who have a mutated IGHV status, patients who are treated with FCR, about half of them are in long-term clinical remission, maybe even 15, 20 years and beyond, and may even be cured with 6 months of FCR chemotherapy. They have a similar outcome to an age-matched control population. The downside of chemoimmunotherapy like FCR has been that the chemotherapy component can cause damage to the bone marrow, which leads to something called therapy-related myelodysplastic syndrome, or even rarely acute forms of leukemia that typically have very poor outcomes. And that proportion of patients is somewhere in the range of 5 to 7%. And so because low-risk disease may also be effectively treated with more targeted, time-limited approaches, and that there's more broad availability to utilizing effective novel agents in this population now, the likelihood is we're going to start to see less and less FCR utilized for low risk disease. This is a list of several targeted therapies that have been utilized to varying degrees in the past or potentially in the future. Ibrutinib was really one of the the first and led to a complete revolution in CLL with regards to targeted approaches and being able to demonstrate high levels of remission and long-term remissions, even in patients who were previously resistant or refractory to other chemotherapy approaches. So again, ibrutinib or Imbruvica targets BTK, this enzyme in the B cell receptor signaling pathway. We don't use a lot of ibrutinib any longer because there are so-called second generation or selective BTK inhibitors that have less, particularly cardiovascular toxicity. So more commonly, acalabrutinib or zanubrutinib are being utilized in CLL. Venetoclax is the currently available BCL2 inhibitor, again, which is able to induce rapid cell death through this mechanism called apoptosis, induce deep remissions, even high levels of so-called measurable residual disease negative states where you can't detect with available tools in the peripheral blood or bone marrow. Idelalisib is a PI3 kinase inhibitor. It has been around for quite some time. It also targets this B cell receptor signaling pathway, although a different component of it. It's been somewhat limited because it's not as effective as venetoclax-based strategies or BTK inhibitor strategies, and does have a somewhat less favorable toxicity profile with a lot of inflammatory complications involving the lungs, liver, and GI tract, as well as infectious complications. So it's not commonly utilized. And coming, but not, well, I guess it is technically here now through perhaps compassionate access, pirtobrutinib, which is targeting BTK in a slightly different way. It's a so-called non-covalent or reversible BTK inhibitor and has demonstrated the ability to overcome the rare patients who have resistance to covalent BTK inhibitors. So just again, exploring this question of, is there an optimal BTK inhibitor? Again, these are the three available BTK inhibitors. They're all excellent drugs with respect to disease control and maintaining the disease and long-term remissions. They are taken indefinitely, which is both responsible for their long-term disease control, but also renders patients on long-term BTK inhibitor therapy, potentially exposing them to long-term toxicities related to these drugs. But they're all very effective. There's no clear difference in survival when they've been tested head-to-head. The primary difference among the drugs is that the second generation drugs are associated with less cardiovascular toxicities, in particular atrial and potentially ventricular arrhythmias. As a class, they all can promote bleeding through inhibition of platelet function. Usually that's mild bleeding, but it is important to be aware of this risk for patients who might have higher risks for bleeding complications, like taking anticoagulants or having very low platelets. As a class, they also lead to high blood pressure. The selective BTK inhibitors may have a little bit less of some of these more minor toxicities, like aches and pains in the muscles and joints, diarrhea, skin rashes. They're generally speaking, they don't suppress the blood counts too much. Maybe zanubrutinib, slightly more neutropenia. They all carry a risk for infection. And again, because they all require or are managed with indefinite therapy, the immunosuppression related to these drugs is something that can be a potential problem and something that needs to be carefully monitored for. We've certainly seen outcomes in patients on chronic BTK inhibitor therapy, for example, related to viral infections, including COVID-19 being associated with either more severe disease or even infection-related, deaths for patients on clinical trials. So this is something we are very kind of cognizant of and does enter into the decision making process. BCL2 inhibitor, venetoclax, as I said, induces rapid cell death. It requires monitoring for something called tumor lysis syndrome. This results in potential electrolyte and kidney dysfunction. It's very uncommon if you manage it appropriately with appropriate prevention through hydration and medications like allopurinol to reduce uric acid levels, appropriate lab monitoring, and using a ramp-up schedule over several weeks has essentially, almost eliminated the risk of significant tumor lysis syndrome. But it does unfortunately mean there's a little bit of, there's a lot of visits to the clinic or the lab to monitor these issues over the first 4 or 5 weeks. But fortunately, it's an uncommon toxicity as long as you adhere to these strategies. The main side effects really are low blood count, so they need to be followed to make sure that particularly the neutrophil count and platelet counts remain sufficiently stable. Low neutrophils often respond very nicely to growth factors and can be managed. GI toxicity is the other common side effect. And more recently, although it came on the market as an indefinite approach, similar to the BTK inhibitors, it's really been utilized now in time-limited approaches, combining with these anti-CD20 monoclonal antibodies, obinutuzumab and rituximab, over 1 year with the ven-obin regimen and over 2 years with the ven-r regimen, so that instead of being on long-term therapy like a BTK inhibitor, patients now can have treatment-free intervals that can last several years and may be beneficial in some cases. First-line treatment considerations really, therefore, are trying to determine for an individual, might they be preferably treated with a continuous approach like a BTK inhibitor or a time-limited approach like chemoimmunotherapy, venetoclax and obinutuzumab, or these newer combinations of a BTK inhibitor with a BCL2 inhibitor, ibrutinib and venetoclax, or acalabrutinib and venetoclax. The decision-making is influenced by patient-related factors, their values and preferences, their fitness level, what health problems they might have, what their prognostic markers might demonstrate, as well as in some cases, availability through funding. To kind of summarize how first-line treatments compare, simply put, the targeted therapies perform better than chemoimmunotherapy across essentially all subsets of CLL patients. Perhaps one could argue that the outcomes are similar in low-risk disease, but even in that situation, we have seen the more recent targeted therapy trials compared to FCR and BR have been associated with improved PFS and probably improved long-term outcomes. In particular, there's not really a risk of these secondary MDS and AML that occurs with chemoimmunotherapy with these targeted approaches. So, as I said, chemoimmunotherapy is being phased out largely in favor of one of these other excellent targeted therapeutic approaches. What's maybe not so clear is how do targeted therapies compare against one another. So one thing we know for sure, again, is that second-generation BTK inhibitors perform better than ibrutinib, not because of better effectiveness really, but because of lower toxicity. We don't really know if there's an optimal second-generation BTK inhibitor. Acalabrutinib and zanubrutinib are both excellent and considered comparable. We don't really know if indefinite BTK inhibitor therapy is better or worse than these other time-limited venetoclax-based strategies. Trials are ongoing to determine whether or not 1 year of Ven-O performs, how that performs against indefinite BTK inhibitor, or some of these BCL2 and BTK inhibitor combinations, how they perform against other venetoclax time-limited approaches or indefinite BTK inhibitor therapy. So this is an area of ongoing investigation. And so when we're approaching this decision in the clinic, there are a whole host of factors that may influence how we decide to treat individuals. That's kind of summarized in this table here. I'll just highlight a couple of things because for the sake of time, for patients that have high-risk disease, for example, a mutation in p53 or deletion 17p, if the goal is to induce the longest remission possible, indefinite BTK inhibitor therapy would be the preferred strategy. Venetoclax-based time-limited approaches are still effective, but they'll be associated overall with earlier relapses. For patients who might have high bleeding risk factors, for patients who might have significant cardiovascular comorbidities, perhaps a time-limited venetoclax strategy would be preferred. There may be patient factors that weigh into this. Some may have a preference for an all-oral regimen, like ibrutinib and venetoclax, not wanting to come back and forth for the intravenous monoclonal antibody treatments. They may have a preference for a time-limited approach in a treatment-free interval, and perhaps not exposing to the chronic potential toxicities or infections associated with long-term BTK inhibitor therapy. And overall tolerability may weigh into this. Again, venetoclax is often very well tolerated and often a preference for patients. This really summarizes how those decisions might lead to an algorithm and approach to managing patients. And again, for the sake of time, I think we'll probably leave this for you to review in the slide set. But ultimately, again, each of these characteristics, both patient and biological characteristics, have a number of excellent options now available for treating their disease. Probably the study we're most interested in hearing about is this German cooperative group study, the CLL17 trial, which is looking at this question of indefinite BTK inhibitor therapy compared to a time-limited approaches. So we're expecting a readout from this in the coming short while. And this is something that we're all very interested to see the results of. It's a key question in the field to determine if there really is, if time-limited approaches may be just as or more effective than indefinite BTK inhibitor approaches. Quickly, considerations at the time of relapse. Again, it's really important to make sure there's an indication for treatment. If there's not an indication for therapy, it's certainly considered appropriate to continue with active surveillance. We would consider repeat prognostic marker testing for P53. The immunoglobulin heavy chain gene status does not change over the course of the disease, and so it only needs to be tested once. But P53 mutations or deletions can be acquired and may influence treatment decisions. We don't really have a lot of current access to resistance mutational testing to specific targeted therapies, although that's an area of ongoing research and interest. And it's important to recognize what therapies have been tried and what the outcome was to determine what might be the next approach. For somebody who has relapsed after a treatment-free period, they may be able to be retreated with the same regimen and have an excellent outcome. For those that are resistant, switching to a new class may be required. And for those who are intolerant, there may be benefit to switching to another agent within the class. For example, those who perhaps are intolerant to ibrutinib may benefit from a more selective BTK inhibitor. So general themes within treatment options at relapse: targeted agents are again superior to chemoimmunotherapy. So we've not used chemotherapy in this setting for many years. As I've mentioned, our options are often to switch classes depending upon what their first or most recent line of therapy was. Venetoclax-based retreatment is certainly available if you've had a 12-month or longer period of time off therapy. So again, switching classes over time is common. We don't really know if there's an optimal sequencing to this. That's again another subject for ongoing studies. But we do know that patients who relapse or are resistant to one class of drugs are able to get benefit and often respond for a prolonged period of time to the other class of treatments. Over time, patients may become refractory to both BTK inhibitors, covalent BTK inhibitors, and venetoclax-based treatments. So there are a number of options in these double refractory or double exposed patients. This is an area of active research. Non-covalent BTK inhibitors may be able to overcome that resistance. Selected patients may be candidates for cell therapeutic approaches like allotransplant. Clinical trials evaluating novel agents, BTK degraders, novel BCL2 inhibitors, and CAR T-cell therapies are also sought after when patients are faced with these challenges. Looking to the future, I think we've summarized this in the last slide, but understanding and overcoming resistance to novel agents is an active area of research. and these agents that may be able to still capitalize on the activity of the B-cell receptor signaling pathway through different therapeutic strategies are actively being investigated. As I mentioned, we're really looking forward to the results of randomized controlled trials comparing indefinite BTK inhibitors to more time-limited approaches involving venetoclax. There's a lot of interest in understanding how best to use disease response or MRD status to determine how long or what treatments patients should be treated with. This is not yet ready for clinical practice, but is even as recently as a couple of weeks ago, the UK FLAIR data became available again, helping us understand a little bit better how we may be able to utilize some more sophisticated response assessments to determine how long and what treatments patients might benefit most from. There continues to be investigations of novel doublet and triplet regimens, particularly looking at various risk subgroups and trying to optimize or advance the novel immunotherapeutics, and CAR T-cell therapy as a key one is also a subject of a lot of active clinical investigation. And so with that, I look forward to answering any questions you may have and participating in the Q&A later in this meeting.
Thank you, Dr. Fraser, for that very informative presentation. And like you mentioned, I just want to take the time to direct the audience to attend the Indolent Non-Hodgkin Lymphomas and CLL/SLL Q&A, which will be starting shortly. Thank you and see you there.